Live now.
Hello, good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on PPH management then and now. Doctors, as you know, at Hetero, we market products in multiple therapy areas, for example, in dermatology, gynecology, gastroenterology, pulmonology, etc. We have a very strong R&D background because of which we try to develop products, keeping patient benefit in mind at all the times. Our endeavor is to improve patient compliance and ultimately hope for a better clinical outcome. Doctor, we have developed NSAID patches, rivastigmine patches for patient compliance, and for us at Frinza, gynecology, obstetrics, and IVF is an important therapy segment. Apart from oral tablets like Didropal and Mylotin, we also market products for vaginal health like Feminora and Pelitra. Recently, also we have introduced, as you know, a vaginal film containing lactic acid under the brand name Silora. Now, doctor, recently we have introduced carbetocin under the brand name Carbiact. Carbetocin we know is used for PPH, and we also know that PPH is potentially a life-threatening condition, and no one really hopes to get a PPH in their practice. PPH requires an intense management. To speak more about PPH prevention with carbetocin, today we have got Dr. Rekha Rajendra Kumar with us. Madam, welcome once again.
Thank you. Thank you, Dr. Prashant.
Dr. Rekha Rajendra Kumar is MD, DNB, FICOG, FIC-MCH, PGD, MLE, Fero Reproductive Medicine. Madam is Medical Director of Miracle IVF Hospital and Chandana Hospital, Bangalore. The achievements of Madam, the first thing I always say, is first rank MD University exam. We know what is the MD exam, and first rank university is, Madam, certainly a great achievement. All India topper in ICOG Reproductive Medicine examination. Madam has been practicing gynecology for past more than 31 years. President-elect for BSOG 23 to 24. South Zone Coordinator Foxy Committee, Infertility Committee. Chairperson Infertility and ART Committee, KKSOGA 2020 to 22. Madam has over 15 original articles and one case report and one poster presentation ESHRE Conference 2021. More than 100 radio and television talks, 40 newspaper articles, all on women's health. With all this, Madam, I welcome you once again, and over to you for use of carbetocin in PPH and PPH management then and now. Over to you, Madam.
Okay, I'll share my slide first. With your permission, Dr. Prashant and Vijay.
Yes, Madam.
Is it seen? One minute. Share screen. Share. 1 minute, 1 minute.
Yeah, now we can see. Yes, we can see. Put it on.
1 minute, 1 minute.
Yeah. Slide show.
Yeah, fine. Thank you, Dr. Prashant, for that very elaborate and kind introduction on me. As you said, actually, I've been practicing for the past 32 years. In the beginning of my decades of practice, first 2 decades of my practice, it was more of obstetrics and gynec, and later on, I converted myself into totally an IVF specialist for the past more than a decade. So I have the experience as an obstetrician, the other side, and as well as an IVF specialist now. But as you said, it is a nightmare to get a PPH in our practice as obstetrician. That is for any obstetrician. When we talk about, it is the very important topic. In and around, we talk about the prevention of PPH, because that is really a demoralizing situation, especially because these cases are highly unpredictable. When we think that everything has gone on very smoothly, she got good contraction, delivered nicely, then the gush of blood starts, and that is really a nerve-breaking situation for us. So let us talk on this very, very important topic, and let us see how much we can prevent this situation. So let me proceed without much ado. Yeah, so there comes carbetocin. This is the molecule we are going to concentrate on after little introduction about the PPH and treatment of PPH. Carbetocin is a smarter, superior, and safer choice. All three, yes, I agree on that. We have become much relaxed now in our practice with PPH since the molecule of carbetocin has evolved and come to the shelf. Let us talk a little bit about the postpartum hemorrhage. What is postpartum hemorrhage, or what we call as a PPH? It's as it is written, it's a very, very unfortunate situation, but it is not that common, fortunately. Now, why we are so scared of postpartum hemorrhage in spite of practicing more than 2 decades, 3 decades? We are really scared when we think of postpartum hemorrhage. Let us go through all the slides and let us know why we are so much worried, why carbetocin has made our life much better. Why it is a problematic thing? Because let us take about little bit of the statistics. The maternal mortality, coming to the maternal mortality, it's the leading cause of the maternal mortality. That's a PPH I'm talking about, accounting for about 35% of all the maternal deaths. Look at that. 1 out of every 3 women, that is when there is a delivery, there's a 35% chance, there's a maternal mortality is 35%, means out of the entire world mortality of the women, 35% happens at the time of delivery. That is too much. Then maternal mortality ratio, what we call as MMR, in developing countries was 240 per 1 lakh live births. It's always calculated as per lakh live births. In developing countries was 240 births compared to 16 in developed countries. Again, the postpartum hemorrhage is a big contributor there. Global PPH incidence, the PPH incidence per se, 14 million women suffer from PPH, be it mild, be it moderate, or a severe one. And what is it? Let us talk about in our future slides. But that many women, so it is so many women, parturiting women, do suffer from the PPH at one point of time, either one of the deliveries. Incidence of PPH is reported as 2 to 4%. That is, out of 100 vaginal deliveries, about 2 to 4 do suffer from some degree of PPH, and it is little more, about 1 to 1.5 times more when it comes to the cesarean section. Though cesarean section is a planned delivery, the abdomen is opened, you can hold the uterus, the anesthetist is there, it is done in the operation theater under good light, you have an assistant there. In spite of all the positive factors considered about the cesarean section, unfortunately, the incidence of PPH is around 1 to 1.5 times more in cesarean section compared to the vaginal birth. Coming to the PPH incidence in our own country per se, 38% of the maternal deaths are due to the PPH. Isn't it a very, very big contributor? Yes, all of you do endorse on this fact. 25.7% of the global deaths take place in India. That is a very, very big chunk. That is, out of the global 100 deaths, around 26 happens in our own country. And 2/3 of these attribute to PPH. So it is, all the statistics do exactly tell us or endorse the fact that PPH is a major contributor of maternal morbidity as well as mortality. India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. Now, what are all the problems this postpartum hemorrhage is going to cause? It can cause the problem at the time of delivery, soon after the delivery, or later on. What does it cause? There is a significant increase in the hospital stay. Why? Because the maternal morbidity is increased. That mother can have prolonged bleeding for a longer time, even on the 2nd or 3rd day. She may get endometritis, that is a uterine infection. She may be very weak, maybe receiving blood transfusion, not able to walk around, not able to feed the child, wound may not heal well, be it a cesarean or an episiotomy wound. So whatever, the maternal morbidity is higher, which reflects in a significant increase in the hospital stay. That means the expenditure is more. Higher inpatient mortality also. The chances of mortality is much more, be it soon after the delivery because of uncontrollable severe PPH. Let us talk about what is severe, etc. The nuances of the facts I will tell you little later, but it is because of a very high bleeding, in the sense larger volume of blood loss, or it may be because of infection, or she may even die because of the thromboembolic episodes. So these are all the different incidences, the contributing factors directly because of PPH or indirectly contributing factors. Major impact on the lives and health of not only that woman. She might have had lot of problem. The pain is more, the infection is there, she's suffering. Not only that, it does not stop there. It affects the health and lives of the affected people also. Like if the woman is staying in the hospital for a long time, the husband or the relatives have to commute between the hospital and home for a longer time. The expenses are more. For the small kids at home, suppose the second or the third delivery, the first child is at home and the child is missing the mother. And with all these small problems, if it is just a morbidity, prolonged morbidity, someday the mother is coming home. But imagine cases where it is a mortality. She is lost forever. Imagine the trauma, the mental agony of the family, the husband, the close relatives, the mother, and especially the first child. Who is going to give mother's love? Who is going to take care of that first child? Who is going to feed the child, fill the tiffin box, and send that child to the school? Who is going to receive that child when that child comes from the school? So a lot of psychological trauma, psychological problems are going to arise. So these may look secondary, but there are a lot many things that happen, and all these things come to our mind. And that is why in the very beginning I said the postpartum hemorrhage is a nerve-breaking issue. It is not just the medical problem. It is not just the obstetric problem. It is a very big social problem, because lot of other intertwined problems are there. Many dependent issues are there. Okay, then long-term psychological impact on the affected woman. Not only the affected woman, because that was a very big damage to her entire health, and the psychological problem is more. She's really tarnished. It was a very black spot in her entire health career, and she wants to forget that issue. Some people even do not want to get into another obstetric situation. Like they say, please, madam, please do tubectomy, or please do vasectomy to my husband. I don't want to conceive again. Many of them do not even come back with another issue. So they don't want to have another pregnancy at all. So these are all the impact of postpartum hemorrhage. Let us talk a little bit about the clinical findings. What does it mean? We are not talking about the traumatic PPH. All of us know that PPH is widely classified into atonic and traumatic PPH. We are not talking about the postpartum hemorrhage that has caused because of the trauma. We are talking of the atonicity, or the lack of tone of the uterus. That means that there is no uterine contraction. What does the uterine contraction do? When the uterus contracts soon after expelling the placenta, it becomes so hard, like a cricket ball, and that uterine contraction is because of the contraction of the myometrial fibers, where there are interlacing blood vessels, and the blood vessels are kinked, and thus it arrests the blood supply. So there is no blood flow outside the uterus from the uterine cavity and outside. So when there is no uterine contraction, or the uterine contractions are smaller, feeble uterine contractions, when they are mild uterine contractions, the vaginal bleeding is more, because the myometrial fibers have not squeezed the blood vessels. So vaginal bleeding is when that becomes more. The mother tries to compromise. Any kind of bleeding is compromised in the beginning by tachycardia. That is, heart beats more in the pretext of compensating for this blood loss, but the next stage would be non-compensatory state, or what is called as a circulatory collapse. Look at the right side of that. We have just put small things there, like what are the clinical findings in PPH in terms of degree of shock. The first one is a blood loss. If it is around 500 to 1000 ml, that is only 10 to 15% of blood loss. In that case, the blood pressure is not changed. You are checking, the bleeding is there. You are checking the woman, but her blood pressure remains almost same. But the symptoms would be little bit of palpitation, because it's a compensatory situation. As I've already told, the maternal tachycardia is a very early sign, and it's a compensatory stage where the palpitation, that is because of the tachycardia, the dizziness, all these things do happen. Next comes the mild stage, where it is little more. It's around 1000 to 1500. She's lost 1.5 liters of blood. It's around 15 to 25% of blood is lost. So the blood pressure starts falling. It is out of that compensatory phase, the blood pressure, because the blood volume is reduced in the blood vessels. The woman presents with weakness, sweating, but the tachycardia is still there. It's the early sign of shock. In the first stage, she's not in shock, whereas in mild PPH, the shock has started. Moderate, little more. She has lost up to 2 liters of blood. 35% of blood volume is lost. The blood pressure, systolic blood pressure we are talking about, is not more than 80 millimeter. We have to get alerted in the very beginning. That's at the 500 to 1000 ml itself. That is a tachycardia. The woman says, I've got palpitation, or when you check, the tachycardia is there. The blood pressure has not come down, but we have to be alerted. We have to be sharp enough to catch her there and to take all the measures. Okay, the moderate is not a good situation. We are not happy. Patient is shifted to ICU. She's restless. She's delirious. She's pale. You can make out that skin is cold and clammy. She's pale. Tongue is pale. Blood, urine output started reducing. So there is oliguria. Severe is a very difficult situation. Massive hemorrhage. 3,000 ml or 3 liters of blood is lost. There is almost half of the blood volume is gone there. There's a blood pressure is really fallen. It is not more than 50 to 70. Renal perfusion is not there. There is renal shutdown. So there is anuria. So these are all the different stages of shock because of the blood loss. That is because of PPH. Diagnosing postpartum hemorrhage. I told in my previous slide that we have to catch her early. How do you catch her early? The initial evaluation is by rapid assessment of patient status. Look at her tongue. Look at the blood pressure. Catch her at the pulse, that is tachycardia. The hypertension may not be there. The vital signs are most of the times in the initial stage, except for tachycardia, are not compromised. The blood saturation remains normal. You have to take critical assessment of the blood loss. We put something called underpad below the buttocks of the patient, which are highly absorbent, and that might have absorbed a lot of blood. So you should really be so critical, so vigilant, and so doubtful about the blood loss. You should be really able to make out how much is lost. You may think around 500 she has lost, and it may be 1500 because the underpad might have taken a lot of blood. It might have absorbed, or the blood may be in the bucket. Blood may be behind the patient's buttocks, or it may be on the floor. So if you have not really assessed, that is a very difficult situation, because you have to act very, very fast. Examination at the time of hemorrhage, the assessment of the entire genital tract, that is to rule out your traumatic PPH like any hematoma, uterine rupture, etc. Examine inside the uterus. If at all there are small placental bits, put your hand right up to the fundus and remove that placental bits. Ultrasound may be necessary. Rarely we need the help of ultrasound, because most of the times clinically itself we are able to assess. Ultrasound is just to know whether there is any broad ligament hematoma, or there is something that is placental tissue remaining inside the uterus. Most of the times it is not necessary, nor do you have some time to do all these things. You will take around 1 minute for the ultrasound machine to boot. By then it is too much of time lost for that woman. Anyway, so evaluation of the uterus to check for the uterine inversion, another important thing, but I don't think anybody will miss, and anybody will skip the diagnosis of uterine inversion. Anyway, coming to the laboratory parameters, CBC, complete blood count, very much necessary. Not only the hemoglobin, the hematocrit is very, very important. Platelets, because they are the coagulating factors, very, very important. Coagulation study is very important, because you should really know any time she will go to the flip side, that is DIC or disseminated intravascular coagulation. So laboratory parameters have equally important role. Now, I told all about the how critical the PPH is and how it has a direct impact on maternal morbidity and mortality. Having known that, what are the challenges in diagnosis of PPH? It always comes with little challenge. Why? Though we have to diagnose early, we have we have some challenges, because PPH is diagnosed by, as I have already explained in my previous slide, the visual estimation of blood loss. You can't sit and measure, because the blood is absorbed and it is all around. You can't sit and put every drop into some measuring bottle or a jar and keep checking. So your visual estimation is very important, and you should probably 10% overestimate the blood loss. Vaginal bleeding sometimes may be really concealed until you put your hand. Recently, I had a patient, had a normal delivery, went to the ward. She was totally normal. There was no blood loss. But when I put my hand on her pulse, there was little tachycardia. It was around 110. Then I put my hand inside the uterus. One big clot came out of the uterine cavity. That means it was so much concealed. Even when I had pressed the fundus of the uterus, that hadn't come. Until and unless I put my hand right inside to the fundus, the uterine cavity, and removed that clot, such a big clot, then the bleeding also stopped, uterus got contracted. So imagine that these are all the concealed blood which is inside the uterine cavity. And I tell you that uterine cavity is such a baggy thing, such a big muscular organ, that it can hold a baby, a big baby, or even twins. So we can imagine how much of blood clot it holds. So how much of concealed blood can remain there. Okay, then alteration in the pulse and blood pressure. Again, one has to be very vigilant. And flabby uterus, because the uterine has not contracted. The tone of the uterus is not there. Challenges: one, delay in the diagnosis, as I have told. Be very vigilant. The pulse or little bit of the patient's dizziness, early drop of blood pressure, all these things should tell you, check for PPH. Many cases of PPH occur without any identifiable risk factor. Yes, this is exactly what I told right in the beginning. Many of the PPH cases do come out of the blue. You think that everything is normal. She is absolutely normal antenatally. The mother never had any history of PPH in the beginning, that is in the previous pregnancy, not a big uterus, not a big baby, not an obese mother, not twins, nothing, but suddenly you will have that gush of blood. So it is need not be in high risk candidates. It can be in anybody. Okay, visual estimation, I don't have to reiterate again. Under and overestimation of the blood volume also can happen. This is one more challenge, but underestimation is more dangerous than overestimation. Even if you overestimate, that is fine. If you one more dose of carbetocin, that is fine, but don't underestimate, because that may be too late, and that may not only for the patient, for you also. It's a very big medical legal issue, and it's an unpardonable situation. Yeah, that's done. And next, coming to the complications. What are the complications of PPH? Little bit I have already touched upon in my previous slides. I suppose postpartum depression, I don't have to enumerate on that again. I have already told. Another important issue, look at that, is the anterior pituitary ischemia, that what we call as a postpartum syndrome, or a Sheehan syndrome, what we call, where the pituitary gets damaged because there is an ischemia to the pituitary. The blood supply was an insult to the pituitary, and because of that, there is a hypogonadism. There's a secondary hypogonadism. Anemia may last long. Indian women are basically anemic. When you check a hemoglobin, usually it is 9. And on top of that, if she has lost blood, it's from pan to the fire. So the fatigue is going to be more. the blood transfusion and its own problems, the battalion of problems. Most of the times the infection is not carried from somebody else like HIV or HBsAg, but still we are not happy to give blood transfusion. Let us prevent that by carbetocin. Myocardial ischemia, yes, because there is an insult to the myocardium, because the blood supply to the heart is not there, the oxygen carrying hemoglobin is not there, etc. Dilutional coagulopathy, if the coagulating factors are consumed, like disseminated intravascular coagulation. And the last thing which nobody can dream of is death, and a very unfortunate situation. How do I take care of this before I talk about carbetocin? What am I supposed to do in labor room? What is called as a third stage of labor. What is third stage of labor? Is as soon as the baby is out, the second stage of labor is done, and third stage of labor is the delivery of the placenta. As soon as the baby is out, now we know that there is something remaining, that is placenta, and we have to remove the placenta. And once that is done, the placenta is expelled, the uterus contracts, and the bleeding does not happen. Okay, so this is the third stage of labor that could be managed with what we call as an active management of the third stage of labor. So that is called as an active management. Why we do? Because we want the placenta to come out. There are three important steps in active management of third stage of labor. One is injection of uterotonic agent. Let us talk about or dissect on this issue a little bit later, what uterotonic agent we have to give and why carbetocin scores over many other traditional long-term, which have been used over long time, the drugs over those uterotonic agents, how the carbetocin has taken over. So one is whatever kind of the uterotonic agent you have to give, that is, you want the uterus to contract. The second is the cord clamping. We do delay the cord clamping, yes, for about few minutes, about 1 to 3 minutes, when everything is fine, like the baby has cried, not much of bleeding there, the mother is fine, etc. But certain situations where the baby is preterm, baby is not crying, so or it's a diabetic baby, big baby, polycythemic baby, these are all the situations where we don't want delayed cord clamping. We clamp the cord very immediately and separate the baby and give it to the pediatrician or the neonatologist, and then perform what is CCT or controlled cord traction. I don't have to go into the details of how do we perform the controlled cord traction, how do we do that and prevent the uterine inversion, etc. But this is what we do, the controlled cord traction, as soon as the baby is separated from the mother. Third is assess the uterine tone immediately to ensure the contracted uterus. So make sure that uterus is contracted. If the uterus is not contracted, you may have to massage on the uterus, put your hand inside the uterine cavity and remove the placental bits, look for the tear, etc., etc. Okay, fine. That is the treatment of third stage of labor. Now let us talk about the prevention of postpartum hemorrhage. This is very, very important for us. Why? Because of whatever I have told so far, that is the impact or all the different problems the postpartum hemorrhage carries along with it. So we don't want the woman to have the postpartum hemorrhage, suffer from the postpartum hemorrhage, and then come out of it. No, that's a strict no. What we want is the very beginning, that is a prevention. We don't want her to get into this problem at all, and that is what is prevention, and that is exactly what the carbetocin does. What the practice of prophylaxis of PPH is improvement of the health status of the mother. We want to keep her hemoglobin in the antenatal period itself more than 11 grams %. Identify the high-risk women. Again, I have already told that PPH need not come in high-risk women. It can be in anybody, but there are high-risk women who are known to have more incidence of PPH compared to the tonic PPH. I'm talking about more incidence of a tonic PPH compared to the low-risk women, like the women who have twins, the women who have history of previous PPH, placenta accreta syndrome, placenta previa, a big baby, obese mothers, prolonged pregnancy, prolonged labor, instrumentation during delivery, aged mother. So these are all there's a big list. These are all the women who are the high risk women. So we have to identify them. We have to probably in the antenatal period, we have to give more time to them, because you have to see to it that her hemoglobin is always better. You have to check how her nutrition is, how is her diet, is she taking enough protein, is she taking iron tablets properly, etc. Okay, then plan for the institutional delivery, very important. These women have to be told high risk or low risk. Meet anybody, we have to tell them that institutional delivery is the only way for delivery, and absolutely no scope or no place for delivery outside any kind of institution. Like home delivery is a strict no-no, because as I have already told, PPH can happen in anybody, Tom, Dick and Harry. Strict vigilance of all women in third stage of labor, yes, because you have to catch them very early regarding atonic PPH. Practice active management of labor, third stage of labor, I've already told. Examine for the afterbirth, that is the placenta and little bit pieces or the bits of membrane which may silently be hidden there. So we have to take them out, because after you are given carbetocin on any drug, the uterus will contract for some time. But if the afterbirths are still remaining inside the uterine cavity, once you shift the patient to the ward, there she may start bleeding, or there may be a secondary PPH. Okay, explore the uterovaginal canal, etc. If you have used an instrumental delivery. Recently, a day before yesterday, I applied forceps to a woman, delivered nicely, locking, traction, everything was fine. Baby cried well at birth, everything happened. But when I explored the uterocervical canal, there was a deep tear in the lateral vagina. So the lateral vaginal tear was quite deep, and I had to suture right from the apex. So identification of these things are very, very important, because the PPH can be atonic or traumatic anyway. So now let us talk about the uterotonics per se, timings and the use. When do we give the uterotonics? What are the uterotonic ones? Which increase the tone of the uterus, in the sense they make the uterus hard like a cricket ball, so that the bleeding does not happen. The timings of the administration can be crowning of the baby's head. That is, the baby's head is distending the perineum. It is about to come out at the delivery of the anterior shoulder. That is, baby's head has come out and shoulders are coming out. They are distending the perineum. It can be at the end of the second stage of labor. That is, as soon as the baby is out, and that is the time we give the carbetocin. The third one, that is at the end of the second stage of labor. That is, as soon as the baby is out. Remember this point, that carbetocin is given, one, as a preventive measure, not for the treatment of PPH. It is to prevent PPH. And second is, it has to be given at the end of the second stage of labor. That is, as soon as the baby is out. You cannot give at the crowning of baby's head, nor can you give at the delivery of the anterior shoulder. Okay, the last is following the delivery of the placenta, like what we give ergometrin, etc. The prophylactic use is for the prevention of PPH, and as I have already told, active management. It's a routine in third stage of labor, the use of all the uterotonics. Third is therapeutic use. The PPH has ensured, and then you are managing that PPH again by the use of uterotonics. So these are all the places, and this is all the scope of uterotonics. And what are those molecules? Oxytocin, age-old, traditional, is a mother molecule, is oxytocin. The latest one is the green, what I have mentioned is the carbetocin. Ergometrin, symptometrin is a combination of ergo plus oxytocin. Misoprostol we give orally or even vaginally, rectally, etc. is another molecule in the tablet form. Now coming to the PPH treatment, some women still require treatment for PPH, unfortunately. How much ever you have been clever, how much ever you have been prepared and vigilant, in spite of that, PPH can happen despite your active management of third stage of labor. All the components of active management I have already reiterated. PPH treatment may be required where no preventive agents are available. So unfortunate, or after failure of prophylactic use. Sometimes you might have given carbetocin well on time. You might have started the oxytocin drip. You might have done the proper active management of third stage of labor, but we have no one to prevent. Sometimes it can happen beyond our hands. So it is sometimes the failure of the prophylactic use of uterotonic drugs. Coming to the drugs, that is the tonic PPH, oxytocin, misoprostol, and injectable prostaglandin, which I have already told, the prothrombotic drugs which cause the thrombin formation and seal the blood vessel, like tranexamic acid, quite innocuous ones, and the recombinant activated factor, factor 7A, uterine tamponade, that is the cavity of the uterus you fill and you make sure that the bleeding does not happen. And fourth is surgery. We are not talking about the second, third, and fourth, that is prothrombotics, because our entire topic today is on carbetocin. Prothrombotics, uterine tamponade, and surgery is for us like obstetricians, but we are not talking about them here. We are just talking about the carbetocin and its comparison with other sister concerns or the other uterotonics. Let me talk about the blue table that is on the right side. Here we say again the stage 0, approximate blood loss is less than 500 ml, that is less than 10% blood volume is lost, and symptoms and signs are none, something similar to the previous one which I mentioned. Then comes the alert line. You should become alert. You should press the bell, call one more sister, call one more doctor, make the anesthetist ready, start another IV line, call for blood, write the blood transfusion form, take the blood for lab sample, etc., etc. So that is the alert line. So 500 to 1000 ml blood loss, volume is 15% blood loss. Again, patient is fine, no symptoms, or maybe a little dizzy, or she has tachycardia. Active line, I have mentioned, but again, it is the blood loss. The second is the volume, how much is lost, and third is the last column is the signs and symptoms, like what she develops. The very, very unfortunate is 3 and 4. It is very difficult. The fourth one is a very dismal situation. The prognosis is so dangerous when the woman loses more than 2000 ml of her blood, or it's a 40% of blood is lost. Imagine, that is a very precarious situation. Coming to the management, there are many, many drugs which we have been using over ages. The new kid on the block is our carbetocin. Coming to the oxytocin, our mothers were using this drug. The oxytocin is need for appropriate training to the clinical staff. I'm talking about the shortcomings and the advantages of all the different kinds of drugs. The regular patient monitoring is necessary. The shorter half-life. Let me tell about this bit later. Need for other uterotonic agents sometimes, because that is not the only drug. I may have to use the ergometrin along with that, or a misoprostol along with that. Symptometrin is a combination of oxytocin plus ergometrin. It significantly increases the risk of elevated blood pressure. If the woman is already having eclampsia, preeclampsia, essential hypertension, this is not the drug, because the ergometrin increases the blood pressure. There is increased incidence of nausea and vomiting. Coming to the disadvantage of oral misoprostol, the same drug we use transrectally and transvaginally, but the oral misoprostol is a good uterotonic, but it takes some time to act. But the patient invariably complains of diarrhea, nausea, vomiting, because it acts on the bowel so much that there is a hypermotility of the bowel. Methyl ergometrin significantly increases nausea and vomiting, and also the blood pressure. What does our big body, that's the WHO, say? WHO recommendations on the use of carbetocin or any uterotonic. What does it say on a uterotonic? It says that use of an effective uterotonic for the prevention of PPH. Again, it's a prevention is the golden word here. Prevention of the PPH during the third stage of labor for all mothers. To effectively prevent the PPH, again, prevent only on uterotonic, one uterotonic should be used. So don't use combination of many drugs for prevention. Find one drug, such a drug where it is only one kind of drug and one dose will give is a short solution. The uterotonics to be used can be oxytocin, carbetocin, misoprostol, etc., etc. But ultimately, when you put all the things, advantages, disadvantages together, it's the carbetocin that scores over many others. Now, coming to the carbetocin in comparison to the age-old molecule, that is the oxytocin. The carbetocin is available in a room temperature stable formulation. It is a room temperature stable one. Let me just talk about that, enumerate on this drug. Oxytocin and oxytocin and ergot alkaloids should be kept in refrigerator. You know that cold chain is very much important in oxytocin. Heat stable formulation of oxytocin is not available. It has to be maintained at a temperature of 2 to 8 degrees only. So that means cold chain system, the cold chain maintenance is very important right from the manufacture to the pharma storage up to till we give it to the patient. So this cold chain is very, very important, and there may be a problem anywhere. Our untrained sisters may not know that it has to be in the refrigerator, and there may be no refrigerator in the labor room. There may be no power in a primary health center. The power may be failing repeatedly in the medical store. So these are all the situation where you may not even know that oxytocin has gone out of its ideal storage temperature. So these are all the problems with the oxytocin. So also the carbetocin was like that previously, but now it has made a lot of change. It has evolved. The resource poor countries do not always have the cold chain transport, as I mentioned. So the storage capabilities may not be that optimal. So the carbetocin is the one that is stable at room temperature. So we do not need any kind of refrigeration. It is just the room temperature. And so even if our sisters do keep it by the side of the patient, that is quite okay for us with carbetocin, unlike the oxytocin. It has shelf life of about 24 months at 30 degrees and 75% humidity. It avoids need for the cold chain. Yes, I have already told that. And this is provided in a vial form. This is what exactly I was telling about. That is a room temperature stable carbetocin. That is little bit of biochemistry about oxytocin and carbetocin. But carbetocin was created by making several modifications in its original form of oxytocin, got evolved, and ultimately something came as a patient-friendly one, and that is carbetocin. It is a synthetic, long-acting analog of oxytocin. This is what I was telling, but it is used for the prevention of postpartum hemorrhage. Please excuse me if I may be, because I am repeating this word, that it is for the prevention, because young obstetricians should know that it has to be used for the prevention of postpartum hemorrhage. The posology and administration is, it is the one vial that contains 100 microgram of carbetocin in 1 ml of solution for injection. So that is a very small quantity, can be given in the deltoid muscles. So the carbetocin is a single IV dose of carbetocin. It's 100 microgram administered after the delivery of the baby. It can be given intramuscular also after the delivery of the baby is sufficient to maintain the adequate uterine contraction. So it has to be, it's just 1 ml, administer it either IV or IM as soon as the baby is out. So that prevents the uterine atony and excessive bleeding with the efficacy comparable to hours of oxytocin infusion. Not only the one shot of intramuscular oxytocin, even oxytocin infusion, when you compare that, I am going to explain this with my future studies of comparison with the large volume of patients who have been subjected to the comparative study. So everywhere it is a carbetocin which says that I am better than your oxytocin. So carbetocin has shown a significant change in the drastic reduction in the blood volume that is lost. So there is a reduced need for additional uterotonic agents. What do we need as obstetricians? That we do not want many uterotonics to be used. One buttock you give carbetocin, one buttock you give oxytocin, subcutaneous you give some other drug, intramuscular you give prostaglandin, orally you give misoprostol. No, I don't want to use so many drugs because the patient will start immediately nausea, vomiting, shivering, and whatnot. So sometimes, as I said, there is no cold storage that is there, or patient, our paramedical staff may not be aware of that. So no cold storage. This is what we want. Good tolerability. That's a good symptom-free period from the patient, or the complaints are much less, and early onset of action, good efficacy, and longer half-life. This is another important thing. Let me tell you why that is. Look at the right side tabular column. It is the comparison between carbetocin and oxytocin. One is onset of action, IV and IM carbetocin versus IV and IM of oxytocin, almost same. Again, the next is very, very important. The blue highlighted bar is very important. Why? I'll tell you. Look at the fact there first. It's the duration of the action. Carbetocin, when it is used IV, it is for 60 minutes. It acts for 60 minutes. That is 1 hour once given IV. But IM, once given, it acts for 120 minutes. So it is very, very important. Now, similarly, when you check with the oxytocin, it lasts, the IM once given lasts for only 30 minutes. So you have to give the oxytocin in drip. It has to run for hours together. Unlike carbetocin, the carbetocin is for 120 minutes, whereas this is 30 minutes. Look at that. So there is a lot of difference. The half-life is again almost same. I don't have to tell much about that. So the important bottom line statement of this slide would be a single IV injection of carbetocin achieves the uterine activity within 2 minutes and lasts approximately for 1 hour. Carbetocin can increase the rate and force of spontaneous uterine contraction. Of course, this is not for the uterine contraction before the delivery. It is not for the delivery of the baby. The uterine contraction for the prevention of PPH. So the important fact in this slide is the duration of action. If given IM, not only IV, IM is much, much more compared to the oxytocin. This is what I want to explain to you in this slide. Coming to the next, this is not to tell much on this. The carbetocin has 24-fold less potent regarding the waterlogging, like the unwanted side effect of oxytocin is waterlogging, and that is much weaker in carbetocin. So again, I want to say is waterlogging is much lesser with the use of carbetocin. So there is a reduction in the risk of hyponatremia. Oxytocin displays high structural similarity to vasopressin, which is a hormone that is involved in the regulation of water resorption. Water retention in the body, that is because of oxytocin, can lead to disturbance in sodium levels. Oxytocin has antidiuretic effect, that is again waterlogging, and IV infusion may cause water intoxication and thus hyponatremia. Severe hyponatremia, less than, say, I can say 117 or 115 of sodium, patient may become little delirious, confusion, etc. So water intoxication has been reported in women. Treatment with the oxytocin, when you have used for longer hours of oxytocin, the drip for continued hours of oxytocin may cause this problem, and the carbetocin does not do that. So to date, no cases of hyponatremia, that means no cases of waterlogging, have been reported with the carbetocin. One more advantage. So what about the clinical evidence? Why are we saying that carbetocin is a golden molecule? Why are we saying that carbetocin is scoring over oxytocin or other drugs like the methyl ergometrin or misoprostol? I have evidence here, and I have come out with these trials. So the very important is the champion trial. That's a leading trial. Why I'm saying it's a leading trial is because look at the subject volume. The volume of patients involved with 30,000 women. It's a big volume. So not only 30,000 women, it is across 10 countries. So it's a global study where India also took part in this study. It was a non-inferiority double-blind study, and it was a randomized trial. Look at the fact. Compared to what are the objective of the champion trial? It was to compare the effectiveness and safety of the investigational heat-stable carbetocin, that is when it is not kept in the refrigerator, versus the oxytocin in prevention of PPH and in vaginal birth. So all the facts you have to consider here. So it is for the vaginal birth, it is the carbetocin versus oxytocin, and for prevention. And as I have already told, 30,000 women were involved. There were two primary outcomes that were set. One was the proportion of women with a blood loss of about 500 ml, and the second was a proportion of women with a blood loss of about 1000 ml. So these were the two primary outcomes when the study was done, the carbetocin versus the oxytocin. So the study said that the frequency of the blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior. It did not say that it is superior, but it said that it is non-inferior to oxytocin. When it was compared with the oxytocin, it was not inferior. The use of the additional uterotonics, intervention to stop bleeding, and the adverse effects did not differ significantly between the two groups. They said with 30,000 patients being studied, both the arms are same. One arm carbetocin, the other arm oxytocin. So coming to the conclusion, the frequencies of the expected adverse events did not differ significantly between the two groups, and thus they concluded, the study conclusion was the carbetocin was non-inferior, if not superior, to oxytocin for the prevention of blood loss of 500 ml or even 1000 ml. Another study also said the same thing. Of course, the volume of the study was little lesser compared to 30,000. This was only 617 patients in carbetocin, 597 oxytocin. The two arms together, probably around 1,000 plus number of candidates. Anyway, the primary outcome was the need for the additional uterotonic, unlike the champion trial. Whatever, the bottom line statement was the patient treated with carbetocin had less need for the additional uterotonics. So they just studied only one fact, that do we need additional uterotonics when carbetocin is used versus oxytocin. So they said the carbetocin had less need for the additional uterotonics compared to those treated with oxytocin. We did not need any other drugs, one carbetocin, and that would suffice. That is what exactly what they said. So one more study, they also said the hemodynamic effects of oxytocin and carbetocin were compared, and their efficacy was assessed in terms of blood loss. The primary outcomes you should check that in terms of blood loss and additional uterotonic needed. So both the things they checked in this study. They studied on the need of additional uterotonics, the blood loss, drop in hemoglobin. That was probably the secondary outcome they checked for, the blood pressure, uterine tone, the uterine position. So many things. So all these were checked with carbetocin versus oxytocin. So they said the single dose of carbetocin versus the oxytocin was, they both have hypotensive effect. Both of them do drop blood pressure probably by 10%. Significantly more women treated with oxytocin needed additional uterotonics, because this was one of the primary outcomes to check in this study. Women treated with oxytocin showed greater reduction of blood pressure compared to carbetocin. Sometimes it may really deceive you because the blood pressure has dropped. You don't know whether it is because of a concealed PPH or because of oxytocin per se. Patient treated with carbetocin showed better uterine contractility, and that's a very good sign. Look at the right side, the green bars, the lighter green versus the darker greens. The lighter greens are that effect of carbetocin and oxytocin on the uterine tone, and the first vertical bar is carbetocin versus the oxytocin. The lighter green bar is bigger in carbetocin. That means the uterine tone was very good with carbetocin compared to oxytocin. Similarly, in the second two, there is a third and the fourth, and the fifth and the sixth vertical bars, every time it was the carbetocin that was better compared to oxytocin in maintaining the uterine tone. A single injection of carbetocin was found to be more effective than the continuous infusion of oxytocin. So this is not just the single dose of carbetocin versus single dose of oxytocin. It is a single dose of carbetocin versus prolonged drip, the continued infusion of oxytocin. So that also showed that a single dose of carbetocin was better. One more study, they said the management with carbetocin is associated with a greater reduction of PPH compared to oxytocin. Let me not go into all the details of this study. There are 1,200 patients in this study, and this was the main outcome there. One more study. So they also said there were 314 in carbetocin and around 600 patients totally. The blood loss of about 500 ml within 24 hours. That's an immediate postpartum. So this was their primary outcome. They said The carbetocin significantly decreased the risk of manual removal of placenta because it expelled the placenta on its own because the uterus started contracting well. So the placenta, there was a cleavage plane, so the placenta got expelled on its own. So the manual removal of placenta was not necessary. We don't like doing manual removal of placenta because one, patients are not friendly because it causes pain. The second thing, we have to put hand right up to the fundus of the uterus and remove the placenta. Sometimes my patient go into the shock, or sometimes the os, the internal os and the external os, and even the uterus start contracting. So you will not be able to remove that. So there are so many problems when we do the manual removal of placenta. And not only that, to top it all, the chances of infection are much more. So the carbetocin had distinct advantage in 83.1% probability of being the best agent that it decreased the need for uterine massage and need for other uterine uterotonics, needless to say. The many studies, the comparison between in the cesarean section versus vaginal delivery, the use of other uterotonics, the primary bleeding, the volume of blood loss, hemoglobin change. There was many studies compared to the oxytocin, the prophylactic treatment with carbetocin after an elective cesarean section reduced the need for additional uterotonics by more than 50%. That's a very significant contribution of carbetocin. So again, there are many studies, the single intramuscular dose of carbetocin versus sintometrin. They also, the assessment here was the other uterotonic agents, the incidence of PPH, the amount of blood loss, etc., etc. They said the reduction in the postpartum blood loss was, there is a smaller drop in the hemoglobin level and less adverse effects, where the study was not between carbetocin versus single dose of carbetocin. The study was not the single dose of carbetocin versus oxytocin infusion. The study was carbetocin versus sintometrin, that is ergometrin plus oxytocin combination. So the carbetocin was checked against many other drugs, against many other variables, and every time it has shown that it has emerged as a superior drug. And this is about the side effects, where much less with carbetocin versus oxytocin, like vomiting, nausea, headache, that is because of the fluid overload, etc., etc. So the side effects were again much lesser in carbetocin compared to the oxytocin, and the other side effects, what as I have already shown, like hypotension, the skin rashes, heart disorders, etc., etc. So the carbetocin is effective compared to other conventional uterotonics. Intramuscular administration of carbetocin at a dose of 100 micrograms, that's 1 ml, is more efficient than or effective than oxytocin for preventing PPH. Its use is associated with less blood loss and better tolerability profile compared to the sintometrin. So in women who underwent cesarean deliveries, I'm in the very last few slides, fag end of my talk. In women who underwent cesarean deliveries, the risk of PPH was lower in the group receiving carbetocin compared to the group receiving oxytocin. There are many such studies who will reiterate the fact, and that has become a confounding fact, that carbetocin was found to be efficacious compared to sintometrin, oxytocin, misoprostol, ergometrin, etc. So intravenous carbetocin demonstrated similar efficacy to sublingual misoprostol plus oxytocin. You may use any other combination in the other arm versus or carbetocin in one arm. So it has really scored over many times. So compared to the other big bodies like the Association of Canada, the Obstetric Gynecological Association of Mexico, Philippines, and Polish, all the other studies, everybody said that carbetocin is a better drug. Whether it is a Canada, WHO, look at the left and the right side of that, everybody said carbetocin, and use carbetocin. So the key messages, the last 1 or 2 slides, this is very important. Please pay attention here. Postpartum hemorrhage remains a clinically significant cause of maternal complications and death. Be wary of that. Be very careful of that. Be open-minded. Be prepared. PPH is common and can occur even in women who are not at all at risk, which I have told umpteen number of times. PPH has a major impact on the lives and health of the affected and their families. Needless to say, we have seen many times the social impact of this. WHO recommends the use of prophylactic uterotonic. This prophylactic is the important word to be underlined. So prophylactic uterotonic as an important step in the active management of third stage of labor. So don't wait for PPH to happen and then take action. Give 1 dose of carbetocin in all 100 out of 100 deliveries and then watch for rest of the things to happen. So this reduces the incidence, the risk of PPH to almost 50%. Carbetocin is a synthetic long-acting analog of oxytocin. It is a sister concern or the elder brother of oxytocin, I can say, created by making lot of evolution in the original molecule. Carbetocin is a new available in the room is now available in the room temperature. It's a heat stable drug, can be kept outside the refrigerator, and we don't need refrigerator anymore, whether it is summer or in winter. Carbetocin has a similar efficacy and safety profile as many other uterotonics, as I have explained all this while. Carbetocin in addition does what? It reduces the need for additional uterotonics. The reduction, you don't have to do the uterine massage to that severe extent, reduces the blood loss to a very great extent. The Champion trial, which is a large volume of 30,000, inferred that carbetocin was a very good drug on par with oxytocin, with the two primary outcomes of 500 ml blood loss and 1000 ml blood loss. Compared to symptometrin, it proved to be a better drug. And the big bodies like the Canada Society of Obstetrics Gynecology, Australian Society, WHO, Federation of International Gynecological Obstetrics and Gynecology all recommend use of carbetocin, and no doubt about that, and that is the drug. Thank you. So we are here and explain everything about carbetocin, and I'm very sure that all of you, the audience here, the participants, totally agree that it is the savior in PPH. Thank you one and all. I stop sharing my slide here and I conclude here.
Madam, thank you very much. Indeed, very elaborate and wonderful session. You got a lot of clarity on uterotonics and PPH.
Thank you.
There are a few questions here, madam.
Yeah.
Like you said, can we say that carbetocin should be given prophylactically in all the patients?
Yes.
In the after second stage?
100%. Because as I have told that there is nothing called high risk to wait and watch for the PPH to happen. Once it starts, it's like a cascade. You don't have time at all. It's like opening a tap. You don't have time. So just be very clever and give it as a preventive drug in 100 out of 100 cases.
Correct. Like, say, suppose, we say that it's very common in patients with uterine atony. But which part of uterine, like prolonged labor, multiple gestation, fibroid, in which cases this PPH is more common?
See, first of all, PPH, there is nothing like that. Like in certain cases, like twins, or as you said, multiple gestation or previous history of PPH, we are more careful, like we are prepared, like I say, RH negative mother. So these are the women, we are more prepared. We are armed that we might have got the blood transfusion ready. We have kept all the drugs ready, etc. But it can happen in anybody. Some of my patients have absolutely had no indication of PPH, and you will be alarmed or you're shocked to see the blood coming out as soon as the placenta is delivered. Uterus is about to contract, but it is not contracting. So it can happen in anybody, but always there is something called high risk category, and you have to be extra careful in these women. But that does not mean that you don't have to be prepared in low risk or a normal patients, normal parturients.
Yeah, expect the unexpected, as they say. You never know. Suppose someone has used oxytocin in the antepartum phase. Can they use carbetocin in the third stage?
No. Oxytocin can be used. Talking about that, oxytocin can be used in the antepartum. In the sense, during the labor. You give oxytocin to hasten the labor process. One certain criteria are met with. Let us not talk about what criteria are met with. You start the oxytocin, or you hasten the labor, intensify the labor procedure. You want her to get more contractions, etc., etc. But carbetocin cannot be there. Yes.
Of course, with oxytocin failure, carbetocin cannot
Yes,
work because they act on the same receptors.
Yes, oxytocin can be used both in the time of labor, that is before the delivery of the baby, as well as after the baby is out. It can be used for the delivery of the baby, that is during the parturient phase. It can be used before the placenta is out. It can be used after the placenta is out. Whereas carbetocin has to be used only after the baby has totally come
delivery
out.
Of baby. Yes,
After
correct.
the delivery of the baby.
Another question, madam. How common is oxytocin fatigue? That patients not responding to oxytocin, and you have to use a second line agent.
It is not that common. We are very happy with oxytocin also, but since the molecule of carbetocin is doing much better, we use carbetocin because of the advantages whichever I have mentioned. There is nothing called oxytocin fatigue most of the time, but there are some women who don't respond to anything. You may have to use a drip or something with the oxytocin, but that's fine. Have a better molecule and a safer molecule, why don't we use that? There is nothing called oxytocin fatigue as such in many of the cases.
Yeah. There's another question, madam. How frequently or on what percentages have you required additional ultrasonics in your practice after carbetocin?
Yes, in my practice, I can say around more than 50%, 60-70% of the times carbetocin alone is sufficient. Say in my practice, around 30% of the times I may need additional ultrasonics.
And if you require, what would you prefer?
I usually give the misoprostol.
Misoprostol, the prostaglandins.
Yes.
And any renal failure cases have you seen with carbetocin?
No, I have not seen it because we give only one dose of the carbetocin. If at all we need after 120 minutes, that is about 2 hours, we may have to repeat one more dose of carbetocin. And first of all, it's a latest molecule for us to have a study over long period. We are not sure.
Correct.
And when you give it as a prophylactic drug, it's a good drug. You don't get into the problem of PPH or the problems that are secondary to the PPH like renal failure. So the carbetocin is used right the 0 hour. And so we are very happy with that. I have no experience on that.
Absolutely. And you really think cold chain is a challenge in metro? Like for example, in big cities, it may not be a problem, but even in big cities, I suppose cold chain is a problem these days.
Yes. It is a big problem everywhere. Actually, I am an IVF specialist. I have my own IVF lab where I have to have the IVF drugs totally in the cold chain system.
Absolutely.
Yeah, whether it is a GNRH, whether it is an RFSH injection, with the 100% strict temperature adherence that is required. Case problem, we have UPS, we have the generator, everything is the need of the hour in all the metro cities because the power supply is so aberrant. It is so hazard that you really cannot believe the power system in power supply, whether it is a rural place or in a city. Even it is all the drug is in the medical store because the medical store, if not attached to the hospital, the standalone medical store. I'm very sure that the medical store is closed at the night, say around 10 p.m. or something. The medical store boy will and go, and the temperature fluctuation is so much. If he does not have an inverter or the UPS system attached to that, definitely the temperature will fall. So imagine about the oxytocin, which does not happen in carbetocin, point number 1. Point number 2, the sisters or the paramedical staff keep changing in many of the hospital. All of you know about the attrition part of that, and we have to keep training them. And sometimes when the patient is admitted in the labor itself, they keep the oxytocin outside the fridge and they keep somewhere in the shelf. It has already reached the labor room where the labor room may not have a refrigerator. Many of the places labor room do not have the refrigerator. It's somewhere in the lab or some other side room or something. So the oxytocin, if they keep outside, you may not even know. We may be examining the patient. We may be busy in outpatient or somewhere else. So we don't even know. So these are all the practical problems we have really faced. So that way carbetocin scores over.
And another thing is, primary healthcare, etc. You have to train the nurses, train the paramedics for oxytocin, that drip, which is not good. So with carbetocin, straight away one can give one injection. That's another advantage, I suppose. A bolus injection.
Yes. And another
Madam,
thing
thank you.
with IM prostaglandin is the prostaglandin. I mean to say it cannot be given intravenous. This has to be, yes, this is very, very important. That is not the case either with oxytocin or with carbetocin. It can be used either IM or IV. Like if the sisters, you're not sure, you might be operating or you might be at the patient, the vaginal end of the patient, you're delivering the patient, etc. They may give directly IV. You don't even know. So these are all the problems with, prostaglandin.
Oxytocin. Yes, oxytocin dosage is also different in different.
Yes.
Maintaining that particular drip may be difficult for a doctor to monitor.
Yes.
Yes. Madam, thank you so much. It was wonderful eye opener for me also.
Yeah.
A lot of things I learned. I've seen myself one case of PPH when I was in my MBBS days. I mean, I was in internship, etc. My God saved the patient.
That's the only thing we pray for.
Correct.
Delivering a baby, that the main thing is let her not have PPH. It's the first thing I pray.
Absolutely.
I know.
So once again, thank you so much for taking time.
Yeah, there is a question from Dr. Anjali. Dr. Anjali?
Yeah. Hi, ma'am. This is Anjali.
Yeah, you have put a question. Doctor, if oxytocin is given for induction, can carbetocin be used in such patients for prevention of PPH? Yes, it can be given. No problem.
Okay.
Yeah, fine. Thank you. I hope I have made my point clear.
Yes, madam. Thank you very much.
With my presentation.
Yes. Thank you very much. 1 minute. Thank you very much for taking time in this session, very busy schedule. Thank you very much for taking time and enlightening us on carbetocin. Thank you all the doctors for participating. And once again, a very good evening from myself and from Hitro. Thank you. If there are any more questions, we'll come back to you.
Thank you, participants. Taking time on this issue. Thank you.
Yes, thank you.